I am Dr. Koopman. I'm working at a heart center Hasselt and Jessa Hospital for almost 10 years now. We are performing all kinds of ablations, but especially AF ablations with 2 operators, and shortly there's coming a 3rd operator to do so. Because our service is still growing, our Department of Electrophysiology is growing 40% per year at this time, so we are at this moment performing about 400 AF ablations a year. We have up until now treated almost 650 patients with the laser technology, and we have done more than 100 X3 procedures up until now. We were already using the 1st and the 2nd generation HeartLight catheter, and our results are excellent. The procedure is very safe. We have few complications, and procedures are going really well, with an average procedure time of around 120 minutes. So that's not bad, but it could be faster. And so X3 is delivering us a quick and a fast procedure. So our procedure times have declined. The average procedure time of the 100 first X3 patients that we did is now 74 minutes, and I'm convinced it will still go down. We are doing half of our procedures in less than 1 hour, and we have a shortest procedure time at this instance of only 40 minutes, which is really great. And that's a skin-to-skin time. It's not the left atrial dwelling time. So these are very fast procedures. Of course, you want your procedure firstly to be really good with good clinical outcomes, but if we can also perform it faster than before, that means that we can treat more patients and we can help more people. An excellent characteristic of the X3 balloon is that now we are performing a continuous rotation and we are continuously delivering energy. So that means that we don't have overlapping lesions anymore, and we create a continuous lesion, and I am convinced that this will reduce the amount of gaps that we will have and the amount of reconnections in pulmonary veins. We are doing some kind of a CT scan by performing a rotational angio on the table. So it gives us the same information as a CT scan, but we don't do it beforehand. If we would have been doing cryo procedures, probably we would do imaging beforehand, because some configurations and some anatomies would not be suitable. With a laser balloon we never have this problem. So yeah, graag. We can tackle every anatomy we want, so I don't need pre-procedural imaging. But I like some imaging during procedure, so we have this by the direct vision, and we also have it by means of a rotational angio. LAO. And that's one of the interesting things about this balloon, that you can adapt it to every kind of vein. It's not a fixed size, it's a flexible balloon with different sizes, so we adapt the balloon to the vein and not the vein to the balloon. That's a very nice thing in this procedure. You have lots of control about everything. I always start with the right inferior vein. There are multiple reasons. First of all, we'll be performing phrenic nerve pacing for the right veins, and the highest chance of hitting it is in the right superior vein. So when I start with right inferior, it's already done, and I don't have to omit 2 veins. If it should happen, it's rare, but it's possible. Pacing mag gaan op de phrenicus. And secondly, it's a quite difficult vein, so one of the most difficult parts of the procedure is already done at the beginning.
And in the right veins, you normally stick with 13 watts?
Yep.
Circumferentially.
Indeed. So we go around with 13 watts.
And there's a slider there on your right hand.
On the handle I have a slider. I can push or pull the laser beam more distally or more proximally, and the rotation is automatic. So don't have to do anything about that. I just have to steer. Left and right is more inside or more outside of the vein.
The arc is now coming from
It's coming
outside
out
the bottom of the
and the other
catheter.
side, yeah. So I have to push it a lot, really a lot, to keep it on track. You see the bright white line is the equator of my balloon. Now I have to pull it back out. A lot.
So you're pulling it out around that branch.
Yeah.
This is quite a large right inferior.
Yeah. Very large vein. Okay, so I think we are done.
And so that took you 3 minutes to go all the way around the vein.
It takes you 3 minutes if you can do a continuous lesion around. It's not always the case. Sometimes you have to convert to some manual lesions.
How long would it have taken you with the older version of the system?
Probably 15 minutes. Of course, you still have to position the balloon inside also. So I know I'm right, so I can get it out now. Otherwise, it's a little bit in the way.
It seems one of the critical aspects is to optimize contact.
That's
before
true.
starting.
So I take my time to position a balloon to make a good contact. And that's half of the work. 13 watts. Verenigd goed.
And it looked like you did just a short trial run to see the path.
Yeah, I always watch I have good contact underneath, so I work until that's okay. And then I try to move it around and see where I come out. So I know I have to push a little bit inside now. At the end, which is logical if you look at the equator of the balloon. So the beam tends to go full circle, and I want it to be a little more oval. So you'll see the beam coming out in a moment. There it is. So it's at the border zone. That's not the real laser beam. That's somewhere halfway. It's a reflection. You can see at both sides, but I know I can push inward a little to keep it on track. You have to push very slowly so you don't create a gap. Okay, there we go. So this beam is rotating automatically by 2 degrees per second, so that means in 180 seconds it should be a full circle. So I have to push this thing more distally now. So you can see this vein is oval shaped.
You're just pushing the slider with your right hand.
I push the laser beam more distally.
And obviously you're seeing an improvement in terms of efficiency, but it sounds like this gives you more confidence about not having gaps.
Yeah, absolutely. So this is the thing we were waiting for, have a method where we can ablate the veins without leaving a gap. So I'm pretty convinced we have very, very good results. So power is one thing, contact is another thing, but creating continuous lesions is very important. Waar is nog? Okay.
And in this case, it looks like you can appreciate some of the lesion formation there on the surface.
You have a little blanching. I don't think it's lesion, but anyway, it's edema. So it means I've been there, which is great. And probably if I've been there with this energy settings, I will have created a good lesion as well. Although the real lesion, we cannot see it. So I'm going to make a little overlap in the circle because the first lesions we make, first seconds are probably not adequate. So we do a little overlap at the end. Okay. So this is it.
And again, that was about 192 seconds in a relatively large right superior vein.
Very large veins. Both of them are very large.
And now we're running the movie mode. It shows exactly where you were.
Yeah. So movie mode is very nice to have, especially if you're also making manual lesions. In this case, it was a full continuous lesion, so I know I've been everywhere. But still, it's very nice to see nothing has changed, nothing has turned during the rotation. Okay, so now I'm going to check both of the right veins to see if they are isolated.
And that's one of the benefits in your technique with
that's
having
why I
the
like to have the
double
lasso,
transeptal.
yeah. So here there are no potentials anymore in superior vein, so this one is isolated. And then the inferior vein is here, also no potentials, that's good. Buis en LO alsjeblieft. So we go for the left veins.
And your left in LAO?
Yeah, that's true. It gives me a little better vision of where I am. So now you are in a nice view for on the left veins. So we're going to inflate here. See what we have. You'd think it's a smaller vein, but it's not. It's also very large, yeah. I'm not really sure. Yeah. But it's not a common, but I don't see. It's very large veins. I don't see the lasso, so it's not a common vein. But maybe we should treat it as if it were a common vein. No, I'll have to do it like this.
And in the left superior, you do dosing a little bit differently than on the right.
You mean in positioning?
The dosing.
Yeah. In fact, both. So for the right veins, I like to have the sheath down to make good contact with the inferior portions. And for the left veins, I like to have the sheath upwards. So that's for positioning, 13 watts counter clock. So I use 13 watts for the right veins to go around everywhere in rapid mode. So now we are going around with 13 watts for the left veins, but only the posterior side. The anterior ridge and the anterior carina I will try to do with 15 watts. Because that's the thickest tissue, so that's where I want to give a lot of power and a lot of energy.
So now your rapid mode, 13 watts going counterclockwise.
Counterclock. So I started at 12 o'clock somewhere. So we'll treat these veins as two veins. It's not really common ostium, but it's two huge veins.
I come into the posterior side.
Yes. So there it is, coming out. Now I have to push inside continuously, not briskly. You see the edema has made my vein smaller. That means I have come out of the vein. So I'll have to adjust this a little. Like this. Getting back where I was.
And if you had a narrow carina here, you could switch to manual mode.
Yeah, but you see, I don't need this
to
treat this as a narrow carina.
Yeah.
If I go a little inside, it's just a little, then I have very good contact at the carina. Which is in fact quite broad, as you can see. I still have to push more distally. Okay, so now I'll have to pull it out again.
And you typically treat the carina from above and below?
I try. It's not necessary, but I always try. 15 watts. So heighten up the energy a little. Give some more power at the anterior portions here. And try to get out of the vein again. And do a wide
So now you're
lesion.
using your right hand to pull the slider back.
Now I pull it back.
And move more antral.
Move more antrally. Okay, that's goed, hè? So I'm where I want to be. So I'll do one manual lesion on the anterior carina, just to make sure I've given all the power I've got there. Oh.
And again, you can appreciate the edema formation.
Yeah, you see here, you see the blanching of the tissue very well. You see where I've been, it's nice white. Where I haven't been, it's still a little, I don't know, pink.
And you like to place one manual lesion here because it's the thickest portion?
It's the thickest portion. 12 watts. Okay.
Letting the movie mode play. How frequently do you find that you don't have to rotate to move the blind spot?
Almost always. If you were good for a 360 degrees contact, you don't have to move for the blind spots. I always try to go behind. So now let's have a look at the superior vein too. So they're all isolated. So that means we can have a little more risk for the left inferior vein. That's 4 really, really huge veins.
Yes.
Even this one, still huge. So the anatomy is nice here because this is the anterior carina. So if you could turn just a little. Yeah, okay, that's good. Now we understand everything well. Yeah. Start up, go counterclock, 13 watts. So in fact, this vein will also try and give 13 watts all around. I don't like to stop for this vein, so we'll have to see what we do for the anterior ridge. Inferiorly, it's a little narrow. So I try to push a little on the sheath to give me a little better contacts in the inferior portions of the vein.
So you're starting to push in
Now I have
now
to
on the
push a
slider?
lot here, really a lot,
Yeah.
to make this turn. Okay, so I don't like to go over this. Try again. No, just continue. So I have to do a little adjustment here. $15 watts.
So you can adjust almost right on the fly.
Yeah. Just give a little more energy here on the anterior carina. 13 watts. So still try to do the carina twice here. Oh, that went a little fast. I'll do that again. So it's also very easy to go back and do some part 2 times. It's almost no time delay. So now I'm pulling out again. Pulling out a lot. That's a little fast. But we're almost there. Okay. So this normally should be it. Volgende patiënt mag gebeld worden. Er mag een elektrische reconversie gebeuren. Misschien toch maar 360 joule geven hier. So we didn't cardiovert. So we'll have to do that by means of a DC shock. It was a quite long-standing persistent AF, so I don't worry, we don't have sinus rhythm now. 360. Ja.
We gaan shocken, hè?
Ja. You have sinus rhythm. Very well done, Helena. All right, so let's have a look where we are. We are inside the vein. Oké, mag ik pacing hebben alsjeblieft? 5 milliamps. Ja? Ja, het is oké. 5 milligram op plasma, het is bijna gedaan hier. Dus, Mocht het scherm vervangen met de laser hier bij mij, dan kan ik ook zien of er capture is. Ja, ja, volgende. Ja. 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 Oké, is goed. So superior vein is isolated. Let's go to the inferior one. Oké, pacing alsjeblieft. Okay, just wait a minute, so I'm not in. Now I'm in, ja. 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 Okay, I think this is local capture. Mocht meer dan één slag pacen hoor, soms. Ja. Ja. Ja, oké, dank u. Ik denk dat het local capture is. Buis mag een beetje RAO krijgen. En dan mag de pacing verder. Wacht even. Ja, nu moet je even wachten. Nu moet je even wachten. Tot ik terug in de venen zit. Anders kunnen we makkelijk VKF creëren. Oké, pacing. What's that? Okay, this is local capture, and there's no coming out. Goed, dus geïsoleerd. Stoppen ze de pacing. That's very nice to see. We have ectopy inside the vein here. It's not affecting the atrium, spontaneous ectopy. Very nice. All right, pacing. Yeah. 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 All right. Thank you. Patiënt mag wakker worden. So we have finished. Again, exactly 1 hour. So we chose to start with HeartLight because up until 2014 we were only performing RF ablation, and we wanted something else for the patients. At that time, a balloon technique, and maybe something that was a little better, maybe something that was a little faster. And so we tried to compare all different techniques that were available, and we decided that the laser technology at that time was the best technique to adopt because it has many advantages of both worlds. It has the advantages of an RF ablation, and it has the advantages of balloon catheter ablation combined together. So if you would ask me what kind of characteristics I like most about the laser balloon, there are a lot of. First of all, the technology is very flexible, and that's something that you want in your daily practice. So you can use it for practically every anatomy. You can tackle every vein, every common ostium, everything you want, and you can adapt the balloon size to the ostium. We don't adapt the vein to the balloon because the balloon is not fixed, it is flexible, so we can inflate it to virtually any size we want. And so we can adapt the balloon, especially with the second and the third generation. The balloon is really compliant and adapts very well to the ostium of the vein. So we have a nice 360 degrees contact around the vein, which is very nice to see because that is the second nice characteristic, that we have endoscopic vision, so we can really see what we are doing and how we are performing the procedure. Moreover, we can also control the ablation much better than we would be controlling any other balloon ablation, because we can titrate energy. We can choose a safer energy for the posterior wall, we can choose a higher energy for the anterior wall. We can pay attention for esophageal crossing and lower energy at that time. So procedure can be more safe because of the control and the flexibility we have with this catheter. We started out treating patients with mainly paroxysmal atrial fibrillation, but I think after a couple of months already we switched to also ablating patients with persistent atrial fibrillation. We are always selecting the patients we ablate on for persistent atrial fibrillation, so we exclude patients with long-standing atrial fibrillation, and we exclude patients with hugely dilated atria. Although I must say that during the years I've become more and more convinced that we can also treat patients with persistent atrial fibrillation, because I think the cornerstone of the therapy is performing a very good pulmonary vein isolation as a first step. So that means that I'm also treating patients with longer standing atrial fibrillation and more dilated atria at this time, with as a first procedure a PVI, which I like to do with laser balloon technology, and then when necessary, and it happens in I think around 1/3 of cases, when necessary we are performing a substrate ablation. We did some studies with it. We had a study with the first 150 patients that we treated, mainly HeartLight Classic. For those patients we have a 1-year outcome, and this is a combined group with around 70% paroxysmal and 30% persistent patients, selected persistent patients, not long-standing persistent, but we have a successful outcome at 1 year of almost 90% with our laser technology, and this is equal paroxysmal and persistent atrial fibrillation. And at 3 years we have still more than 85% of freedom of atrial fibrillation for the paroxysmal group and almost 80% for the persistent group. So those results are very well. X3 has definitely improved our efficiency. Up until Excalibur, we did 3 laser balloon procedures a day, and with X3 now we are performing 4 procedures a day, so that means that we can still grow 25% thanks to the new technology.